Thank you. And we will resume our presentation from our slide what we just read. So we have been speaking about cardiovascular risk factors. We were just talking about diabetes. Diabetes has a massive risk of developing PAD. So about 1 in 3, so 1/3 of diabetic patients are going to develop arterial disease during their lifetime. And smoking and diabetes add up, especially in a really bad combination. So that this is something that we should really aim to avoid, and which we really need to educate our patients on when they start developing issues. What are the typical clinical symptoms of arterial disease? Well, the classical symptoms is the exercise-induced pain in the limb.
Do you have my voice?
Yes.
Sorry for the interruption. Could you please zoom out the slide? We couldn't see it properly. I think it's a little bit bigger and we couldn't see the corners.
Okay. So, okay, so
now it's okay. In that case, it's okay.
In that case, it's okay. So we can try to use it like that. It looks not as pretty, but if you can read it better, let's do it like that. Okay?
Yeah, it's okay. Thank you.
Okay. So the last sentence that probably not everyone has heard was about our patients with peripheral arterial diseases being largely asymptomatic. We have a small percentage that we diagnose and treat, hopefully in an efficient way, but there's an underdiagnosed part that you need to have in the back of your mind. When you are dealing with someone who might not know, they are actually quite seriously ill with PAD. If we try to classify PAD, we base the classification on the progress of the symptoms. In Europe, I'm used to working with a Fontaine classification ranging from asymptomatic claudication and then ischemic rest pain and ulceration. But if you end up talking to somebody who's, for example, American, they might be used to the Rutherford classification, which works just as well, as you can see, but it is very important to make sure you know which one you're using, right? Because stage 2 Fontaine mild claudication is something entirely else than Rutherford grade 2, which is ischemic resting pain. So please make sure both sides are aware which scale you are using to classify the arterial disease. I believe this slide was not included in the original lecture that we uploaded before, but has been added afterwards, so you can take your time to look at it and copy it down if you need it. On top of that, you need to be aware that the disease of the peripheral arteries rarely comes alone. So if you have somebody who has bad blood flow in their legs, there's a 50% chance that their heart is affected as well, and a 30% chance that they are at risk of a stroke as well. Why is this important? Because you need to send your patient to go get a cardiological checkup. They might feel the pain in their leg, but they are not going to feel the pain in their heart until it's too late, until they develop a full-blown infarct, which of course we want to avoid. So first of all, we have systemic arteriosclerosis. Secondly, our risk factors that we talked about contribute to other diseases as well, right? So if somebody has had diabetes for a while, they might have peripheral nerve damage as well and never feel the pain in their legs. And if somebody has been smoking a pack of cigarettes a day for decades, they will probably be too short of breath to ever notice their walking pain. So this is one of the reasons why PID might also be asymptomatic despite the fact that it is very much present. So I am a vascular specialist. Still, I am aware that not every elderly person, not every patient who complains of pain in the leg has arterial disease, right? That's a fact. Other reasons are, of course, much more common, especially orthopedic diagnosis, like vascular of the hip, of the knee. And we also have vascular reasons that are not arteriosclerosis. So especially in a younger person, you might want to think about previous deep vein thrombosis or fresh vein thrombosis that can also cause symptoms very similar to claudication. Well, what do we do to find this out? The bad news is there's no magical high-tech diagnostics for this. But the good news is if you do a really good physical examination and a really good medical history, you can start to get a really good idea and then run a few very selected diagnostic tests to progress from here. So, how do we do the diagnostics? First of all, please ask your patient to take off both their socks and compare the feet. This can help you a lot to assess the limbs. Please compare the skin color and check the temperature of the skin with the back of your hand, since that's a bit more sensitive than your palm. So do a motion that's like this. Then you could check the pulses. I am going to show you how to find pulses on the leg in the next slide, because I believe hands and arms are very easy. You're going to learn that quickly. Hands and feet are a bit more tricky. I'll show you how in a minute. Then you should also always check for wounds, especially in spots that your patient cannot really see by themselves. So check between the toes and check underneath the feet, because those are places they might not have seen in a while if they're elderly and not moving very well. Last but not least, when checking, compare the growth of the hair on the legs and the toenails, because a slow growth can be a sign of bad blood flow. Thank you, sir. Good. So, like I promised, let's talk about how to assess the pulses on the leg. Again, please compare both legs, the healthy one and the one that is in pain. Start from the groin and work your way downwards. So what you do is you place your finger here, you feel for the femoral pulse, and then you listen. If you don't hear anything, that's fine, that's normal. If you hear a little swooshing sound, something like that, then most likely you're gonna find a relevant stenosis, even up here. So first, femoral artery, then popliteal artery, which can be found behind the knee, in the soft part, in the bending part of the leg. Then on the foot, find the posterior artery, which is located behind the inner ankle and on the top of the foot. So just beside the tendon of the first toe, you can find the pulse as well. So those are the 4 points that you should check on each leg. If you find anything that's boring you, or even in patients whom you know to be at a cardiovascular risk, you can do a screening method, which is easily done and needs really few technical equipment. This screening method is called the ankle brachial index. The basic idea is to measure the blood pressure. So down on the ankle and up on the brachial artery on the arm, and then you divide the systolic blood pressure from here and from there. In a normal person, in a healthy person, this is going to be a little bit more, a little bit higher, so you get a value of just a bit above 1. If there's significant reduction of the blood flow in the leg, you will find values of 0 point something. So of course, the worse the blood flow, the smaller the value. So that's a very quick and easy method to get the first idea of the functional situation of the blood flow in the legs of your patient. So how do we find our stenosis? We have 3 basic methods. We have the ultrasound, we have CT or MRI, and thirdly, we have angiography. Let's talk a bit about each of them. First of all, Doppler ultrasound, which is my favorite method. I am honest about that. Why is it my favorite? Because it's easily available at the patient's bedside. It's not harming them, so not hurting them, no X-ray, no risk of bleeding, no needles, which is really elegant, so it can be repeated basically as much as you like. And the imaging gets better and better as the computers are helping us even more to improve our images. What we do, first of all, you can just use your black and white boring old ultrasound probe and get an image of the blood vessel. What you're gonna find is a black blood vessel, so that's blood flow. And then you have white echogenic material, so that's our arteriosclerosis located in the blood vessel's wall, which even can sometimes have a little shadow behind it. So that's a very good method to locate the arteriosclerosis. And then when you switch on the color and measure the blood flow, you can see the stenosis itself, either directly or indirectly. How do we do this? Well, it's called the Doppler ultrasound. Doppler is named for the physical effect, which you probably remember from school, when we have waves from a moving object, so sound waves, or in our case, ultrasound waves, and they change with the direction and the speed of our moving object. So this is why we have a little ambulance picture here. So in a stenosis, you will have increased blood flow. We are shooting our ultrasound waves from our probe onto the little red blood cells, and they're reflected back. So they are creating a little signal for us. So first of all, ultrasound. Secondly, what we usually do is either CT or MRA, which allows us to get a complete picture of the blood vessels of the affected limbs. Again, usually it's legs, so we can include a bit of the aorta and the iliac arteries as well. This helps us, you can compare size. We see our problem. There's a blocked blood vessel here, but we can also check if there's any further problems, for example, up here. That also needs to be included in our treatment plan. So we will sit down in a conference with all the specialties involved, surgery, radiology. We will talk about whether our patient is fit enough to, for example, go under anesthesia, go get an operation, or whether the vascular lesion is approachable by different methods. So that needs really careful planning, and those pictures help us a lot to achieve that. Thirdly, we have angiography, which is a little more risky. Angiography works the same for all the blood vessels, whether we are talking about the blood vessels from the heart, or as we are saying today, about the blood vessels in the extremity. So you go and insert a little catheter into the patient's groin, and then you can go either down on the same leg, or can do a crossover using the iliac arteries and getting to the other side, which is of course interesting if you're thinking you're having a stenosis up here. So of course, if you insert a catheter, you're always risking a little bleeding, but if you need really precise images, that's absolutely worth the risk. On the tip of the catheter, you can insert some contrast matter in order to visualize the blood vessels. And computer software can nicely optimize the picture, so take out all the bone shadow, and you are left only with a picture of the blood vessels, which gives us perfect imaging, especially in the distal end of the limb. So especially in the feet and in the hand, this is the best method to get a good diagnostic. If you find a stenosis that's treatable, you can progress to treat it. We will get to that in the treatment part in a minute. Before you start doing anything flashy, any treatment on site of the stenosis, please think of the basics. So if you have a person that comes in with exercise-induced pain and you find PAD, the basic therapy is managing the risk factors. So you should screen for blood pressure and sugar, and you should treat them. You should talk to your patient about stopping the smoking habit, and you should optimize their cholesterol levels by using statins. On top of that, all our patients antiplatelet therapy to prevent any blood clots forming on the pre-existing arteriosclerotic lesions, and patients with exercise-induced pain should go and see a physical therapist for walking exercise, which helps the body form tiny collaterals and kind of heal itself. Of course, if you have somebody who already has resting pain or chronic wounds, they should not be adding any exercise. But for people in the beginning of the disease, it's a very good and very effective. Right, like I promised, when you do angiography, you can do angioplasty as well. So what does it do? We have a little wire that goes into the arteriosclerotic lesion. You can use a little balloon to flatten the material, to press it into the vessel's wall, and then you insert a little stent. What is a stent? It's a tiny made of high-tech material that's supposed to keep the blood vessel open, so blood flow. Nowadays, most stents that we use on the extremities are coated in drugs in order to prevent any blockage. But especially for the first few weeks when the stent is new, you need to add a second, more potent antiplatelet therapy on top of the aspirin in order to keep that stent open. Oh, what has happened? Hang on, we have lost our slide. That's unfortunately the disadvantage of our untraditional methods, but we are gonna deal with it. Right, this is the review. So we were saying if you insert a stent into a limb, you will have to use dual antiplatelet therapy in order to keep your stent open. If our stenosis or blocked vessel is not accessible for stenting, for interventional treatment, then traditional vascular surgery is always a good and reliable option. This can be the case if the stenosis is too long, if it is too hard to treat by passing a wire through it, or if it is located in a region that is not accessible. For example, if we have the groin or the popliteal artery that is going to bend a lot, there's going to be a lot of mechanical stress if the leg moved, so the stent may fracture, and we need something more flexible and longer, so we use a bypass graft, either from the patient's own venous material or by using PTFE, so plastic artificial material. The idea is the same. We adjust above the stenosis just below and can restore the blood flow. After inserting a bypass, you will also need some kind of either antiplatelet therapy or even full anticoagulation, depending on the type of bypass and the situation afterwards. If we are talking about PAD, what I really want you to keep in mind is the emergency situation, which can present as acute limb ischemia. You need the symptoms which summarize using the letter P, so they are a bit easier to remember. We have, of course, the pain, which when he is cut off rather completely from the blood supply. On top of that, we have no pulses. We have paralysis, so no motor function. We have paresthesia, so the patient's not going to feel it when you touch the extremity. We have pale color of the skin and a perishingly cold temperature. If this goes on for long enough, you might see another P, prostration. So what happens is that the dying muscle cells and tissue cells, they can release toxins and potassium into the bloodstream, causing the patient to go into kidney failure and into shock. So this is really a situation threatening not only the limb, but also the life of our patient. What do we do if we find ourselves in a situation like this? Well, that's how bad is it. This is done using the Rutherford equation. You use this of sensory loss and motor deficit. So you touch the leg and see what happens. Do they feel it? Can they wiggle their toes for you and move the foot or the hand? And if you are a bit experienced, you can try to catch the Doppler signal. So use the ultrasound probe to detect the pulse as well. If all normal, that leg can probably wait to be seen by a specialist until the next day. If all those parameters are negative, so you have no Doppler sound, no movement anymore, and the patient's not feeling anything in that limb anymore, then probably that extremity is going to end up to be amputated. But the interesting part happens here, right? If you have something that's threatened either marginally or immediately, so you have a loss or a little deficit, then you will have, if you're not a senior vascular surgeon yourself, to call someone, even if it's like 3 o'clock in the middle of the day. This, if your patient has to have a chance to get through this, have to act right now. The good news is, even if you do not have to be a vascular surgeon, there are options. What can you do to stabilize the patient? First of all, be generous using painkillers. So what we usually do is we use opioids to achieve some control of the symptoms. And please wrap that extremity in nice clean bandages and nice warm cotton wool in order to prevent any further mechanical damage. Then you should place an IV line. You administer some sedation. We usually administer under heparin. If there's no major allergies, no major risk of bleeding, and generous fluids in order to protect the kidneys and stop the shock and frustration. While the therapy is getting planned and prepared, you should run some basic blood tests for blood cell counts, for kidney function, blood coagulation, and you should use CK and lactate. Both are good markers for the ischemia. It also gives you an idea about the extent of the muscle damage and the risk of kidney damage. So that's a parameter that's worth watching for. If there's a critical, get the vascularization option as quick as you can, or find somebody who does the amputation. And this transitions us nicely to the topic of arterial thrombosis. Why is that? Because arterial thrombosis can look just the same. Just like acute limb ischemia, it can cause pretty much the same symptoms, but it can occur in a leg that has, or in an arm that has no arterial disease itself. So we have a blood clot that has traveled from somewhere else in the body. can be the heart, can be an aortic aneurysm, and it travels with the and it gets stuck. What is that? Sorry. All right. So the blood blocks, all of a sudden blocks our bloodstream. So the diagnosis and treatments for the acute situation are just the same, like we just discussed, right? You need to go to anticoagulation, you need to do the revascularization, and you can also think doing thrombolysis. So insert the wire and trying to dissolve, or like in the picture here, get the surgeon to take the clot in an operation procedure. Afterwards, after we have saved the patient's limb, then we can start thinking about locating the source of that blood clot. So we do electrocardiography, usually overnight, 24 hours, 72 hours, try to find, for example, atrial fibrillation, which is one of the most common reasons of blood clots forming and causing embolization somewhere else. Find what can look like arterial disease, but is not necessarily arteriosclerotic. Well, we have thromboangiitis, which is more common in younger people below the age of 50. It's a lot more common in men than in women. And it's usually heavy smokers who are affected. It is a disease. It's more based on inflammation, and it's usually affecting the small vessels. It can be small veins as well as small arteries. So what you get is a person who has incredibly painful necrotic toe and toes and fingers. It's usually affecting hands as well as feet. And in angiography, what we get is a picture that looks like this. So there's blood vessels missing, like in the sometimes we have a bit of hyperperfusion, so the same part that's getting a bit more of a blood flow. And then we have new vessels, little collaterals, leading the way down here that are twisting and turning like a little corkscrew. So that's a picture that's very suggestive of thromboangiitis. Here, there's no real in inserting stents or bypasses or the vessels. So what we need to do is really try to get the patient to stop smoking. We need to give them intravenous cycles of prestanoids over quite a long time, so 14 days, 21 days, and platelet aggregation, so low dose aspirin on top of that. We usually use 100 milligrams a day. Some countries use 75 milligrams. The basic idea is the same, so just low dose every day in order to prevent additional blood clots. On top of that, you can try a lucky shot. You can try calcium channel inhibitors as well, because they also can help relax the muscles in the small blood vessels and dilate them a bit. So sometimes that's fusion. Last but not least, what I would like to show you is how to use a chronic wound. If you are practicing medicine, whether you're a surgeon or a general practitioner, you're going to see a lot of elderly patients with wounds. And of course, not all of them have arterial disease, but it makes sense to screen for it. So do the screening and the diagnostics, like we said. If you have are up here on the ankle, then you should check the veins as well, not just the arteries. Step number 1, vascular diagnostics. 3, if this goes below skin level, do an X-ray or some sort of imaging and try to find out what is happening underneath, because the extent might be a lot of what you see on the surface, and bones are not affected. So X-ray, please. And should do a little microbiological swab. So my test for the bacteria present. Any open wounds with bacteria. Do you need to treat it with antibiotics? Well, if your patient has a fever and high inflammation, and that's right, you start treating. If this is painfully red, swollen, not smelling good, you should also start your antibiotics right away. If none of those alarm symptoms are present, then you can probably choose a more elegant approach and wait until your microbiological testing is done, and then you can choose a tailored antibiotic therapy that the bacteria and the resistance is found inside the wound. So that's the approach chronic wounds. If you are practicing medicine, you will see a lot of chronic wounds in your lifetime. It's a very relevant issue for you. So whether you're a surgeon or whether you're in general medicine, what should you do? Well, we approach our wounds from three sides: from the vascular side, from the antibiotic, antimicrobial side, and from the local management. So vascular diagnostics means do the screening and the diagnostics for PAD. If the wound is located up here on the ankle, then you should think about veins as well and check the veins, not just the arteries. Secondly, anti-infective management. All open wounds will have bacteria present. If it looks dangerously inflamed, if you're showing the alarming symptoms of infection, like fever, like bad lab results for inflammation and infection, you should start immediately. If you have no alarm symptoms, you can wait for the result of the swab and do a tailored antibiotic therapy that matches your bacteria and your resistance and found inside. Thirdly, we do a local wound management. So nice clean and disinfection, of course. But then you should get your little scalpel out and cut any necrotic tissue, because the necrotic tissue impedes the healing of the wound and harbors the bacteria. So that's not going to help the healing. If you're done, you clean it, you bandage it, and you find your patient a good pair of medical screws that prevents any pressure from getting on here, especially if they are diabetic and might not feel the pressure. So we have three sides. If the wound is below skin level, please do some imaging, usually just basic X-ray, to make sure the bones inside are not infected as well. And usually, if you manage three angles, so vascular, local, and antibiotic, you should get a nice wound healing with a bit of patience. If you do not see any progress, then you should reconsider your initial diagnosis. So that means you should take a little biopsy from the wall, from the active lesion, and send it to pathology. Ask them to check whether this is really a chronic wound or maybe something else like autoimmune diseases or skin cancer masquerading as a chronic wound. Good. So those were my three little chapters for you tonight. So let's please, first of all, thank you for your attention. Sorry for all the problems.